Hey, get in, fellas. We're going to rehab. We're coming to you certainly not live from the University of Colorado Health Campus in Aurora, Colorado. Here specifically at their inpatient residential treatment center for substance abuse addiction, the Center for Dependency, Addiction, and Rehabilitation, or what's called CeDAR. So just want to make sure we emphasize that we are not necessarily representing UC Health today or the organization, but we are very fortunate to be able to get an inside look at what the day of a patient is like when they are in substance abuse rehab. We're going to be joined by a good buddy of mine, Perez, you'll remember from the dissociation episode, to talk to us about the medical component, the psychiatric and medical component of residential rehab. Then we're going to meet Bowen. He's one of the therapists here, to talk with him about the curricula, the programming, the family involvement, things like that during rehab treatment. And then we got a special bonus. Our good friend Shirley came on and made her internet debut. She's a business specialist. So we're going to talk a little bit about the money and how people afford treatment and how insurance and things like that work. So it's going to be a super fun episode. We're super stoked to be on site and in person for the first time today on the podcast. And as always, let's go. Thanks everybody for joining for a day in the life of a patient. Due to technical difficulties, you're going to see Mario and I here talking throughout the scene, but just ignore that because I'll be your host and your guide on this tour through rehab today. So we're going to start at 7 a.m. It's time to wake up and get the day going. And so you'll see here a typical patient room here at CeDAR. So there's 2 patients per room. You can see twin beds set up. They're going to have desks. They're going to have bedside tables and things to put clothes, desks to do their work, separate sink outside the bathroom, which you know is going to be clutch, avoiding roommate conflict and fighting over the bathroom like that. You might be thinking like, man, you don't get your own room. It doesn't look anything crazy like it's still medical treatment, so it does feel to me a lot like a dorm room. It feels a lot like somewhere between kind of medical and home, which rehab often feels like. You wonder about roommates too. Data shows that during the course of medical treatment, that people who are alone in their rooms, especially when they're struggling with the isolation of addiction, actually benefit from having roommates. That it's lonely, it's isolated, both qualitative and quantitative data say that. Plus, we're going to talk about this later in the show. It would be expensive to have your own room. And so having roommates is both not only good for camaraderie and good for fellowship, but also it's good because it's more reasonable as far as cost goes. So I want to, also touch upon right here, this won't be the only time that we talk about boundaries. So any rehab facility, especially CeDAR, is going to be monitoring patient boundaries. Now, these are adults, but they're still in vulnerable positions. They're struggling with things that brought them to rehab in the first place. And so we certainly have a no hanky-panky rule in any sort of rehab facility like this. Specifically, though, they're encouraged to keep in touch. A lot of substance abuse recovery is about fellowship and about camaraderie. So not being alone with that, knowing that you have people that you could call and make friends. So boundaries is a big part of treatment. It's a big part of mental health treatment at large, and that doesn't go away here. Of course, after we get up, we're waking up here, we embrace the day, we shower, brush our teeth, and get ready. It's time for breakfast. So I'll see you all over in the cafeteria. As you can see, the good Dr. Perez and I chumming it up in what we call one of the hallway rec areas of either of the cottages. I want to take this opportunity to explain what the cottages look like. Unfortunately, for patient privacy, we couldn't do a really full tour, but the patient's rooms are in what we call cottages. There are a few of them on the CeDAR campus, and they contain the patient bedrooms, some of these open areas in the middle to be doing activities. You can see me and Richie peek down the hallway here. They have therapist offices, they have group rooms, they have nursing stations, because inevitably this is medical treatment. Having nurses on site to help address medical concerns is super important. There's a lounge area, TV, chairs, couches, board games, card games, inevitably stuff that pulls everybody away from technology and more into hard work, communication, community, and just relaxation, because they're working hard and everything should really be focused on healthy, positive ways that are really long-standing. And because we're over here in the hallway, we'll take this hallway and mosey on over to breakfast. 1 and 2.
I still have not seen that inpatient unit.
So we're in the CeDAR cafeteria. You can see here, no patients though. Of course, we're not going to be showing patients on the tour today for all their privacy. But guys, when you're struggling with substance abuse problems, nutrition is usually a big thing that we neglect when we're struggling in those ways. So it's really important here with the patients. They're getting 3 meals a day. Of course, they have access to food throughout the day. There's going to be nutrition advice and groups on those kinds of things. And so making sure that we're really fueling our bodies well, because treatment is really hard work. We'll see here later that physical activity is a big part of the daily routine. And so we want to make sure that everybody's eating well. And of course, breakfast is a great way to start the day. No skipping breakfast here because we got hard work to do. We're going to cut from here to our first interview with Dr. Perez, who's going to show us some of the medical parts of rehab when it starts with needing a detox and just where treatment tends to start. So we'll see you all in Dr. Perez's office here in a minute. Hey fellas, as we start and continue our tour of rehab, we are back with a good friend of ours, Dr. Mario Perez. If he looks familiar, that's because he is. He joined the show for our dissociation episode within the Freud shit block, talking about dissociative identity and self-states, an important concept that we revisited at the season finale where me, Mike, and Richie talked about such concepts. So we're here today because Dr. Perez, as we all know, is an addiction psychiatrist, specially trained in such a thing. And we're lucky today to have him at his place of work here on the Anschutz campus in Aurora, Colorado, the Center for Dependence and Addiction and Rehabilitation. So, Mario, thanks for joining us.
Yeah, thank you for coming to my office and,
talking it out,
hanging out where I work. So, yeah.
To timestamp this interview, Mario, it is Friday, January 3rd. You and I are in a pickle, a quandary of sorts, because I need your Broncos to lose this weekend for the Bengals to get into the playoffs. How you feeling?
Well, we need a miracle in KC for sure, but I don't know. I don't think they're going to play all their players.
They're not playing, right? Wentz is playing.
I think we have a shot.
Yeah.
You did, beat us last time, so I'm still a little salty. I wasn't going to do this, but
It was. This was on the table. I had to actually sweeten the pot for Dr. Perez by letting him know that if we did this today, he could come to the Nuggets game with me and Richie tonight and see Wemby in person. So we'll see how the Nuggets do tonight against the Spurs. Yeah. That's worth it. Yeah. That's worth it. So we're happy to have him. We're here at Rehab today because we're into the action stage of the stages of change model of treatment. So tell the people about the action stage and
Sure.
Why rehab makes sense as a place for us to be.
Sure. I think I think you guys discussed the kind of trans-theoretical or the change model, going through the different phases, but we're in the action stage here. I think this is kind of where the wheels hit the road and people actually start doing things that get them to change their behavior. They're actually making these hard kind of movements to do it. So.
Absolutely. And if you're just tuning in for this special episode where we're on site, before this in the stages of change, it's pre-contemplation, you're not thinking about change. Contemplation, you're starting to. Preparation is taking the steps to engage in treatment. And right, like Mario said, action is when you start to engage in treatment, start to really engage enough to stop using substances. So, Mario, we're doing this next week, but where you did a pit stop between preparation and action, kind of thinking when preparation goes wrong, and we featured interventions.
Sure.
So a super cool topic. So Mario, that actually gets me started with when we're thinking about inpatient residential treatment, right? So that is the idea that the patients are sleeping here. We'll take you guys on a tour of some of the living facilities later. How does a patient end up here? How does a patient end up in rehab?
Yeah, so I think, they've reached a point where they cannot get help, whether it's by themselves or with their outpatient providers or family members kind of notice and they would recommend them coming in. So you have to kind of, I don't want to say hit rock bottom, but you're getting close to it. And I think, some people can see that coming and they can, decide that they want to come in. You get a referral from your PCP, or you can actually, here at CeDAR, just walk in and, ask to be seen. And they kind of go through the steps and say, hey, what do you need? What type of treatment are you looking for, kind of thing. And we can either set you up. Luckily here at CeDAR, we have outpatient. We have something called intensive outpatient programs where you come a couple days a week and you hang out for a few hours, then you get to go back home. And then we have the inpatient part where you stay here and you kind of get as much as you can here. So
IOP is an excellent level of care, not only for substances but mental health in general. Probably a really slept-on resource as far as you can do 12 hours of therapy a week, usually in the afternoons, build it around your work schedule, some weekend programs. And so IOP is an excellent resource. And so Mario, when you mentioned hitting rock bottom, I'd agree, because if you're at the point where you need to go to rehab, you're really not functioning. You're not functioning at your job. You're not functioning with your relationships.
And you've tried things, you just can't do it on yourself, and you need that extra help, and even more so than this couple hours of it kind of hanging out,
Really interrupting the cycles. We've talked with my buddy Mike Damioli about kind of the cycles of addiction, and that, the triggers and things that really contribute to needing to get away, which is like why we'd end up in rehab in the first place. So Mario, it's interesting because you mentioned referral sources. A patient can't admit themselves. What kind of mental state do you get people when they start the process? Like, where are they?
Sure. So it can vary depending on, obviously, substance, the amount you're using, how much, when's the last time you used, things like that. So we get a good, variation of folks coming in, some who are completely detoxed already, to others who are still pretty even intoxicated and have to go through the detox process here with us. So, that involves them going over to the kind of detox building and kind of hanging out there for a couple days. And they get supportive medications, they get supportive therapies, things like that, just to help them get through that phase, which, it's probably the hardest part of their journey through here.
Do you guys do involuntary care here? Because I can't imagine how jacked a lot of people are to go through detox.
Yeah, we do not do involuntary here. But we can, we've helped people get into that. But fortunately or unfortunately, people are here volunteer.
Yeah, and it's just different vibes, like this is a voluntary facility. They take insurance here. It's not, some rehabs, as we could understand, are cash only. In different places, I think we've all seen like Malibu, Paradise, where celebrities go and can go do whatever they want all day, but are generally in a safe environment. But this is, this I'd say is a nice intersection between a really medical feeling and then a fancy rehab like that somewhere down the pipe.
And it's, it's not a locked facility. I don't think, I think sometimes people think that they can't leave, but they definitely can leave whenever, they feel like they've had enough, and that's okay. We welcome them back, and sometimes I think the action stage, it doesn't go linearly, right? It doesn't go.
There's back and forth, just like grieving. The stages of change are very much a process.
And it can change
like that.
Temporarily, like one day you're feeling like you're there, the next day it's not. So it is a shift, and I think that's important to know too. Like, it's not just going to be like I'm in action phase and that's all I can do is the action. But there is a lot of give and take with that for sure.
Yeah, and definitely want to be thinking about what sets people up for success and what doesn't when they're here. But I wonder, Mario, people here, I think colloquially we understand what detox is, and the word itself means detoxification, so to get the toxins out of your system. But can you kind of give like a bird's eye view of what detox looks like and how we go about it in a medical sense?
Sure, and it depends on, I guess, the substances. So
totally.
Anything you kind of get high on, you're going to come down on it, and I like to kind of say, so if you're filling up, you're going to feel down on the withdrawal. So this is what we kind of try to avoid, and that's what people try to avoid by just keep using. They don't like that withdrawal phase. They always want to kind of be up or maybe in the middle somewhere. But once you take any kind of substance away from folks, they're going to have the withdrawal. And, generally, I think if talking about alcohol, opiates, things like that, they're somewhat similar in the fact that they feel terrible, they're fatigued, anxious, the worst they could possibly feel.
Yeah.
And we help them by either giving them medications, for instance, like alcohol. We'll use benzos, long-acting benzos, to kind of slowly get out and allow you to kind of slowly withdraw. And the same thing with opiates. We can use, like Suboxone and things like that.
Is methadone here?
Methadone we cannot give here, but
special kind of thing.
We do accept folks that are on methadone. It's just they have to be they have to have their methadone shipped in to us, basically.
Oh, interesting. Yeah, there's a lot of regulations around methadone. That was the original kind of like replacement of opiates, was methadone, this very long acting. And if you've ever heard of a methadone clinic, you have to show up every so often. And once you've gained trust and passed drug tests, you could take home some doses. So that's very different than this level of care.
And it's federally regulated, so that's why we can't do it. You have to get like a federal license. It has to be stored correctly and have this, certain boundaries on it. And they did lighten up a lot of the regulations during COVID, and those are actually still in place, so it is much more flexible than it used to be. So
yeah, we've touched on this a little, but I want to reiterate, as Mario was talking about some of the treatments, that for a really long time with opiate, treatment, that really we just treated the symptoms during the withdrawal phase. You did not replace the opiate, which we do now with Suboxone inductions, and that was rough. I mean, people going through opiate withdrawal are fucking miserable, and they're not going to die.
Right.
Which is different from alcohol and benzodiazepines.
Right.
Which, that's why Mario was saying we use long-acting benzos to help taper alcohol out of your system. But that is, in a different way, fucking brutal.
Right.
And can kill you.
Yes, you can die from it. So it's really important to get professional help if you're trying to get off alcohol, because that one, like I said,
I would imagine those are the two main things. How much methamphetamine do you get? How much,
we
other things?
A decent amount of methamphetamine, a lot
Big
of
out here in Colorado.
cannabis, yeah, and it's usually not like one. It's
Right.
usually kind of a combination of all the substances. So I think meth with alcohol, cocaine with alcohol, opiates with meth. It's kind of all over the place for sure, and I think that's
Kids.
just kind of what you see. Yeah.
We don't mix our drugs, kids, especially alcohol, opiates, and benzos. That all shuts down your breathing and leads to bad times.
And unfortunately, with fentanyl, I think they put it in a lot of things. So I think, if you think you're doing maybe just meth or you're getting some benzos off the street, it probably has some fentanyl, has some meth in it. It's just, you never know,
I've heard
unfortunately.
more and more about, fentanyl and other heavy hitting opiates being cut into people's heroin and other drugs. We just had this case that you see up at your alma mater, CU, where the fraternity, there was guys doing coke and a bunch of them had to go to the hospital for presumed opiate overdoses. So test your drugs, kids.
Yep.
You can buy the kits on Amazon. It's super fucking easy. Ain't no thing. Test your drugs.
You
Don't
come
be
to
dumb.
CeDAR, we give you some free ones. We have free
Yeah,
testing
there you
kits,
go.
so yeah.
They're out there, man. They're out there. Get naloxone, have it on the hand. You can get that shit everywhere too now to help with overdoses. So, Mario, how long does the detox? So it's kind of like detox. You're saying it's like the medical step one.
Yes.
To making sure that you're safe to
Yes.
participate in the full treatment.
Absolutely, and it'll depend on the substance, the person. So it usually takes 1 to sometimes up to a week for folks to detox. Like I said, everybody's different. It's hard to really pin down a good time frame, but yeah, I think one to a few days is probably kind of the typical.
And what's the kind of the cutoff point for when they're in that detox for when they can start participating in programming?
It's usually if they're able to, maybe not be in bed all day, not feeling terrible. They can actually walk and pay attention in groups, things like that. So it's
mentally clear enough. Yeah.
Yeah, we call it like green status. So once they get there, they can go to programming. They kind of join lunch and dinner with the other people in the cottages. So it really just depends on how able they are physically to be able to tolerate it.
Yeah, absolutely. I think it's a cool and unique part of this process because I'm sure there's other facilities where you've had to go through that medical detox when you arrive.
Yeah.
So that's what we have the benefit here of being literally right next to the UC Health inpatient campus in the emergency room. And I'm sure there's sometimes people show up for treatment. You
sure.
got to send them over to the ER.
Yep. Sometimes they're just not. They need that extra level, so we can send them in. Get them the help that they need, and then they come right back. So it's kind of nice in that sense. But unfortunately, the ADU is what we call it. That's acute detox unit. It doesn't have all the same equipment that the ED does, but we can definitely get you
More medical than some places and less medical than the hospital. I mean, that's the idea with rehab. You're not at the medical hospital. A lot of them are affiliated with medical hospitals, of course. But this is a lower level of care than would be being in the medical hospital. So, Mario, tell us about your specific role. When do you encounter the patients, and what are you working through when you're talking to them?
So there's different members. Let me just say there's different members of the team, I guess. So we're going to have an addiction and medicine person who kind of does all the detox stuff. You have addiction psychiatrist who's going to come in. That's my role. Talk to the patient, kind of look for other co-occurring psychiatric conditions that we can, start treating right away. I think that's the other advantage of CeDAR is there's not a lot of places that have this co-occurring psychiatric part.
It's often called dual diagnosis.
Dual diagnosis, yeah. So, some places they want you to be completely psychiatric stable before you take care of your addictions, and then other places want you to be completely free of your addictions before you take psychiatric things. But those two are so intermeshed that it's impossible.
Well, how do you end up using a substance if not for some sort of mental health thing, right? We've talked long and hard on this show about addiction comes from wanting to give yourself a feeling or take away a feeling. And that's mental health as far as I'm concerned.
Yep. So so we're lucky that we can do both of those things at the same time.
You touched on this, right? I think if a lot of people think of rehabs being locked, that would mean you need to be in an inpatient psychiatric facility or an inpatient medical facility. So that is a difference between those things. As those places you're locked for your safety, we assume people here, if they're suicidal or if they're, a flight risk, that like they're stable enough to be participating in treatment.
Right, and that's kind of my main goal, I guess, in that first detox phase, is to kind of make sure that they are safe to be here from a psychiatric standpoint as far as safety. They're not going to hurt themselves, they're going to hurt others, and kind of just get them settled in that sense. But that would be my main role.
Yeah.
At
Are you involved in any court stuff or court order treatment here?
No court order. There are studies that show that, this forced treatment doesn't necessarily work. I think at the end of the day, you have to want to do it for yourself for it to really kind of, for it to work.
It's interesting. So. It's like I feel like the idea of involuntary treatment is it's an old thing. It's a relic back from when we thought this was treatable as if addiction was a freestanding, standalone illness.
A moral kind of,
yes. We were just talking about our Bro Motions Hall of Fame a few weeks ago was Robert Downey Jr., and he went to court order treatment a bunch, and it truly wasn't until he went and wanted to get better that it made a difference. And it just shows addiction and those patterns are way too difficult to kick without the motivation. And depending on where you're at in life, the motivation's hard to grab.
Yeah, and even people that come here, sometimes they're doing it because their family wants them to do it, or job. It kind of varies, and it varied success as well. I think you need some of that external motivation, but you also need the internal to really, really get into it.
Yeah, just like anything in life. Mm-hmm. So, do you maintain yourself? Like, are you a part of the team through the whole process?
Yeah. So it kind of, when they're in the detox. Addiction medicine folks, they kind of run point while they're there, and then it kind of transfers over to me once they move to the cottages. So once they're through detox, they're actually kind of in more the IRT or the inpatient residential treatment kind of program. So then I'll take over along with some of the counselors who I think you'll get to meet, and we kind of co-run the team and guide their kind of treatment in that sense.
Yeah, it's very similar to when I've talked about where I worked at the Eating Recovery Center and that like multidisciplinary approach. And so Mario, inevitably, the doctors hold a lot of liability, that's why Mario mentioned doing safety screenings and things like that, while, the counselors, the therapists have less intensive a caseload. And so, you met some of those people like Luis and Grant when we did the male therapist roundtable, that they, have more consistent touch points with the patients because they're more involved with the family and they're more involved. So we'll talk with one of the therapists here, Brian, about a lot of those aspects later. So
and we have different levels. We have nurses that interact with the patients daily. We have behavioral health techs that are also there, kind of keeping eyes on the patients and talking with them and being with them. So many different levels and many different professions coming together, and it is very much a team effort to help these folks.
I think it has to be, and it's interesting because you have to get to inpatient addiction level, to have it be common. I think about the Eating Recovery Center. The eating disorder treatment is the same. It's an addiction, and the treatment model is all very similar. But it has to get to that level for it to become a multidisciplinary approach. It's more rare that in the outpatient world you're getting that kind of thing.
Yeah, no, it's almost impossible to kind of manage all those parts of your life that addiction interferes with and can affect. So I think having all these people in place is what makes it successful.
What percentage of patients that finish have a successful discharge?
About 60 to 70%.
Okay.
Give or take.
Feels right.
And it depends on, I guess, what you consider successful. They stick around, they do the treatment, they make plans to do things in the outpatient. And I think returning to use shouldn't be thought of as a failure either. Right. It's just part of that cycle of it.
I think a successful discharge does not mean that they never relapse. Right. That's not fair. We'll talk about relapse, guys. It is an unfortunate part of the process and not to be demonized because of its commonality and how hard this is. So when I think successful discharge, really I mean like not AMA.
Yeah.
With resources in place, with their outpatient team, with a place to sleep that night.
If we do it that way, I'd probably say like 80, 85%.
Okay, that's pretty good. Yeah. I mean, I as much as I can, having worked in these places and seen it,
It's really hard to say if I were in that rough a shape, if you could finish the process and stare down those demons.
For sure. Yeah, no, I think, and it usually happens, I feel like, in the first kind of that detox phase is really when you lose, like, most people to AMA or ACA we use here, like, against clinical kind of advice. But yeah, I think this first, like, week is rough.
Yeah. We talked with some of the earlier addiction episodes. My buddy Mike, who runs his own treatment center out here, had to go through rehab for heroin use and all this stuff when he was younger. And then Keith Bradley, who's the interventionist, also struggled with substance use and was in treatment himself. And so it really shows, a lot of mental health people obviously, go to give back to those people that help them. And, if you've struggled in this way, the draw to want to help people who are in similar situations is just so strong.
And I think sometimes they're even more successful than the people who don't have a background in it, because I think the patient kind of you can really connect with them. Like, you feel like they know what they're talking about because they lived it, and then that really kind of builds that peer kind of.
Yeah, your street cred is a little more reasonable. I think thinking about the Charlie Brown shows of the '60s, like, if your therapist or doctor clearly never went through this stuff, a patient's just going to be like, want.
Exactly.
So having somebody who's really walked in those shoes makes a big difference in this world, for sure. Well, Dr. Perez, thanks for kicking us off here. So again, guys, this is the start. We want to talk about that medical detox process, the way you'd enter rehab in most cases. And we're going to move on to talking about the clinical programming. What is rehab treatment really like? What are we working on? How is the family involved? So we'll see y'all after the break.
So we're going to spend a lot of time on the tour here in the group meeting room. As you can see here, you can see the AA fellowship rules over on the wall. We're actually going to do a whole separate episode on AA down the line, but I want to focus on group rooms because group therapy is truly a mainstay of any type of rehab, any type of higher level of care. Safety concerns, eating disorders, rehab, doesn't really matter. You're going to be doing a lot of stuff in group. To quote Dr. Perez as we were actually recording this, group time is sacred. All right. This is where you build community. You understand that you're not alone with these feelings. You work on skills. Really, the majority of the learning is done. We don't pull patients from groups. We want to make sure they're learning and understanding. And so I want to talk a bit also while we're here about the different types of groups patients experience throughout the day. Pretty standard, probably to have about 5 different group times throughout the day here at CeDAR. A few in the morning, a few in the afternoon, and a few in the evening time. Talked a little bit about boundaries. So there's going to be a community group. Community groups are really standard in any sort of residential treatment setting in the mental health world, where you talk about how are things going in the community? Are people doing what needs to be done to maintain a positive, treatment-focused environment? If people are not doing that, how can we work on that? How can we set boundaries? How can we support each other to make sure that the environment is positive for everybody to recover and everybody to do well here? Truly, how often do we do that out in the world? Do we take the time to reflect on how we're all treating each other? Do families have family meetings? Do we do these kinds of things at work? So just to be thinking about that, I think community meetings are rather cool. And I've worked in places where we do carefrontations. If people are having a hard time, contributing to the community appropriately and setting a good standard, then we're going to make sure they understand that and how they're impacting other people, because a lot of people don't really learn behaviors impact other people. Outside of community, there's a lot of skill-based groups during treatment. So skills meaning like CBT, cognitive behavioral therapy, and DBT, dialectical behavioral therapy. If you've been on board with this program since the beginning, you know what those are. The CBT skills help us challenge those cognitive distortions or those thinking errors that lead us to dealing and needing substances to deal with those negative feelings. I'm not worthy. I'm not lovable. Themes like that. DBT are those distress tolerance skills where we slow it down, help our patients make better, smarter choices. So DBT skills are really important in rehab because people who are struggling with addiction of any kind have found a way to use substances when they have a hard time slowing it down and when they're not able to tolerate their distress. Outside of that, another big part of substance use rehab are the fellowship groups. So fellowship groups are like AA, Alcoholics Anonymous, NA, Narcotics Anonymous, and the like. We're going to cover those again in a future episode, but you want to get people in the groove of what those groups have to offer, because most treatment centers like CeDAR are going to recommend you being involved in a fellowship program like that. We call them fellowship programs, again, to help you build community, understand that you're not alone with these thoughts, and that, what you're going through is not as isolating as it often feels, and that we can make sure we have support and ask for help when we need it. After these group meetings, there's a little time to work out before or after lunch, so I'll see you over in the gym. pretty nice fitness center. You can tell by how I'm jiving there that I was pretty impressed by this overall, getting a little pump in. So you can imagine physical fitness is a really important part of the treatment. And it's really, as Dr. Perez said at one point, it's the best part of most people's days. So, a big part of treatment is separating from the home environment and really working on building healthy habits and a good routine. And so an emphasis on physical fitness is a big part of the treatment process, so much so that at CeDAR, they have dietitians, they have a personal trainer who comes and leads workouts of the day. Let me tell you, they do not seem for the faint of heart from what I could read up on the wall. But patients are really working on those things. And if you think about the people that are really susceptible to substance abuse problems, it's a lot of ADHD, which requires, ways to get out that energy in a healthy way. And people who, generally speaking, just have some internal restlessness and things that really, really benefit from a healthy relationship with food and exercise. So, right. And so after the gym, we'd say lunch. We won't show you the cafeteria again. But after that, I want to introduce our good friend, Brian Bowen. He's going to become a regular on this show. He's an individual therapist at CeDAR, and we're going to kick it to him to talk about more of the treatment of rehab and what it's like. See you there. Brian, you're joining us in the middle of the day in the life of a patient episode here on the Get In Fellas pod. So we've been in the morning, we've talked with Dr. Perez, we've taken a little tour of campus, and Brian's joining us as a behavioral health counselor. So you learned this with Luis a while back. He is an LPC, so still getting his hours in terms of being a licensed professional counselor, a native of Lancaster, Pennsylvania, and a Philadelphia sports fan. He got his master's in clinical mental health counseling here at Denver Seminary, very popular place. A lot of therapists go here in town. He is a reader, both fiction and nonfiction. He enjoys anything that is addiction and recovery related. A family man with a wife and 3 kids, and a hunter by nature, which makes sense. Central Pennsylvania native. That's what you're up to. So, Brian, thanks for joining. How are you feeling about the Birds against the Pack this weekend?
Feel pretty confident, I mean, if you've watched any of the last, I don't know, however many games, the Eagles got the momentum. Nothing like it was last year. So it's kind of like we're flipping the script. So hoping they can take that momentum into this weekend.
Any concerns about rust with Jalen coming out of the concussion protocol?
I don't think so. He's a great leader, I think he'll do just fine. Yeah.
I hope he was just, they just continued to rest him last week. Maybe he could have played in week 18 if they needed him to. So timestamp this episode, y'all. I'm rocking Ohio State gear because they play Texas tonight. Let's all hope we're happy. Brian, the Birds play on Sunday. So let's hope we're all in a good mood when this episode comes out next week. Brian, again, joining us as a therapist here at the CeDAR Rehabilitation Facility. How did you end up getting into inpatient rehabilitation work?
Yeah, thanks for the question. I'll try to keep this. I have several different versions of this story, but for the sake of time, I'll keep it somewhat concise. So prior to this career, I served 20 years in the United States Air Force. So around 2015, 2016, I was a few years out from retiring, trying to figure out what I was going to do next. And just for the record, I also am in recovery myself from alcohol, other drug addiction. And those are some kind of dark days for me. And just, again, I won't go into all the details of that, just to know that I was kind of at the bottom of things. And add on top of that, I was retiring soon, and I had no idea what I wanted to do.
Unfortunate combination we see with military veterans on their way out of service, really like a purposelessness, kind of like, what do I do now? But also in the addiction field, right? A lot of great people who work in addiction treatment themselves have a story with it. Very common.
Yeah, absolutely. And so it was that point in my life also that because of negative consequences from my addiction, I was, my military career was kind of on the line, really. And so for about 18 months, I didn't know whether I was going to retire or not. During that time is when I started kind of figuring out kind of what's next, and through that entire experience, it just kind of, I don't know, call it God's grace, call it whatever you want. It just came to me that this was my next step to give back, and I didn't know what that looked like. So I just started looking at things, started going back to school, went to Indiana Wesleyan University just for my bachelor's in addictions counseling. And I knew that I wanted to seek higher education, and I also wanted to integrate my faith into just kind of how I saw things, not only from a worldview perspective, but from a therapy perspective as well.
Sure.
And so started at CeDAR actually in 2019, undergrad student, and I was doing a practicum with the family program at the time. So I did that for about half a year, and I guess they liked me enough to want to hire me on. I started working on working in the outpatient clinic as a behavioral health specialist, just working with families, doing some case management stuff, doing IOP groups, virtual groups, things like that. And that's when I decided that time that I was, okay, I want to go back to school. I want to get a higher education. I want to get my master's. And so through that, kind of 3 or 4 year experience working as a BHS and outpatient, and then really kind of wanting to understand what the residential side of the house looked like. I'm like, I really want to do an internship in IRT, intensive residential treatment. And you know what, Stephen, I thought I was going to hate it. The reason I thought I was going to hate it was because I had this vision of working with people long term, right? And I know, and especially, a couple of years ago when there were some limitations with just Medicaid coverage and things like that, that folks weren't here that long. They were here for maybe 2 weeks. But I gave it a shot. I'm like, I want to see what this is like. And you know what? I fell in love with it. I really did. Coming up on a year now. So been working as that provisionally licensed counselor, LPCC, in the residential program here at CeDAR since April of last year. And so that's how I came to be where I'm at.
It's really interesting, too, because when we think about therapy and mental health treatment, we've talked a lot about levels of care on this show, Brian. And I also worked at a residential treatment center for eating disorders, so a different kind of addiction. And it is really cool how much family involvement, the depth of the relationship. And now I'm in the outpatient world, so it's a bit of a switch from what you did and getting to see people long term and more of that gradual process. Yeah, as far as working in mental health, there's pros and cons to all those levels of care. And I think residential, especially with addiction, is a really nice sweet spot when it comes to getting to do good work. So, Brian, your role today as we take our tour of the day in the life of a patient is going to be to think about what is the treatment, we talked medical with Dr. Perez, but what is the therapy, the psychological, the family treatment like for somebody when they're in programming in rehab facilities?
Yeah, so the process begins with admissions. So level of care assessment will happen during that assessment. It's like a 90-minute assessment. We'll assess for bio, psycho, social, all these aspects of someone's life. And then a determination will be made for that level of care. So if it is residential, then that individual will go through detox, which we have a 24/7 medically supervised detox unit. And so generally speaking, the individual will stay there for at least 24 hours, depending on the medical necessity, the complications with their withdrawal and all of that. And at that point, in all of this, I just wanted to say it's, this is up to the individual. This is their choice to be here. This is not a mandated program or anything like that. Of course, we encourage as a treatment team in almost, I'm not going to say all, but most situations that the step down from detox would then be intensive residential treatment, which
it's really a lot about like stages of change. That's how the model for addiction block we've been doing. And this is in our action stage, Brian, kind of thinking like this is really, we've prepared, we show up, and then we get into the action stage. And you're right. Not everybody who shows up for that assessment is really ready to be in that action stage. And so I'm sure you experienced that a lot.
Yeah. And I think we'll get to that in a little bit. And I'm glad you brought it up because most folks are in the pre-contemplation stage of change when they come in. And even through the residential treatment experience, whether it's 30 days, 45 days, what have you, we do often find that folks are still kind of on that contemplative stage of change. But yeah, so anyway, circling back to kind of the day in the life, what would happen next with that patient if they do say, okay, yes, I really do want to try this residential treatment out. They will, here at CeDAR, transition to one of the cottages. We have 50 beds, so we have two separate cottages, and they'll have a roommate, and they'll enter into our programming, and it's called intensive residential treatment for a reason, right? It's pretty, there's a pretty heavy load of programming that happens on a weekly basis. They'll start their morning 6:30 to 7:30. They have breakfast. They come back for their medication. At 7:30 to about 8:30, then they have what's called circle up. There's like a peer leader, someone that maybe has been here for a few weeks. They lead the circle up, maybe do some daily meditations, kind of go over the schedule of the day. Then they'll hit their first process group at 9 a.m. They'll do a psycho ed group at 10 a.m. They'll probably have some kind of maybe team-based care meeting with their provider, sometimes also with the counselor, any time between 11 and noon. And they have lunch, and then there's some, in the afternoon is when they have their individual counselor assignment. So that's when I will meet with them individually. We'll normally do an hour session. Sometimes, depending on my caseload, we'll meet up to 2 times a week, sometimes an hour, sometimes 30, 45 minutes. And then after that, well, in the middle of that, they have fitness too. I want to make sure that I mentioned that because that's a real big part of.
We got a nice, tour of the outdoor facility, but also the gym, and that's those kinds of things. Because you're right. I mean, these are people looking to establish healthy lifestyles and make good long-term change, and developing that part. I'm sure is a big thing for any patient. I mean, you're there for 30 to 45 days. You're going to want to exercise, ideally.
Yeah, and I like how you said that. Kind of like that part of the person's recovery journey is just kind of getting used to a new routine, a structured routine. And in residential treatment, at least at CeDAR, a big part of what we do, like the heart of what we do, is really helping patients stabilize, right? Stabilize medically, stabilize clinically. I call them the big three, right? Getting your fitness in, getting your nutrition in, and getting your sleep. Because a lot of these folks sleep. I mean, they've had no real structure or rhythm to their sleep or their lives, really.
Yeah, I mean, insomnia as a marker for trauma, depression, anxiety is often the source of substance problems, right? Like, how can I sleep? Get me something to sleep. People drink themselves to sleep. It's a tough cycle.
Yep. And so that's a big part of, maybe that's why I had some pushback at first when I didn't know what residential was going to be like, because I got to help these people make these big changes in a short amount of time, and they're going to be coming out of here ready to go. Not the case, right? What I've come to learn, and why I really appreciate it, is because this is such a critical part of someone's journey, right? Is helping them set that foundation, right? For recovery. Like what does that even look like, right? So that's why I like it so much. So yeah, then in the afternoon they'll have they'll have like a deep, they'll have DBT groups. So we'll have DBT groups that are run by the behavioral health specialists. Sometimes we have sober living folks come in and give a presentation. Sometimes we have just psycho ed classes. We have one class called Recovery Discovery, which is just it's like a educational class specifically pertaining to aftercare, right? So a lot of these folks will come in with really no resources at all. They don't know about sober livings. They don't know about different outpatient programs or the lower levels of residential care. So we make sure that we address those on a regular basis to help people find those resources, get them set up so when they discharge, they're not just stepping out into nothing, right? They have a solid aftercare plan. Yeah, and then, they'll have dinner, come back, they'll have a community meeting, like a fellowship meeting, AA, CA, NA, any of the kind of fellowships, recovery, Dharma, you name it. We offer a pretty wide variety of those. They'll have an evening group there, reflections before bed, and then, lights out at 10.
That's really awesome. I mean, it should be a full day, and with some time to, they have TV in their dorms, opportunities to go, hoop and do the gym and things like that Brian was talking about. So it's a busy day, as it should be. When you're only in that intensive level of care for 30 to 45 days, we've got a lot of ground to cover. So, Brian, I'm interested. You touched on DBT, which people who've listened to this show know that the big thing about DBT is working to slow things down, tolerate those emotions. So in this situation, we don't end up using substances or other behaviors. But what are some other, so learning those kinds of coping skills, learning healthier ways to handle, what are other, as you see it, like foci throughout treatment and programming? Like, how are we helping people who come in such bad shape?
Yeah, I mean, we have, the typical evidence-based interventions like, the CBT, and like you mentioned, the DBT, other kinds of therapies like that. Now, when I'm working with somebody one-on-one, I really try to collaborate and understand kind of where they're coming from, what kind of lands the best with them. And then I kind of adjust my, interventions toward what's going to be the most helpful for that person. But by and large, what you'll see is the cognitive models, right, that are, can be very helpful for people that struggle with substance use disorders, because we're talking about, thoughts, behaviors, feelings. We're talking about learning different practical coping skills, repetition, understanding, like you said, kind of how to slow down, how to kind of observe one's thinking and feelings and things like that. And then, a large part of really the, I think, part of the healing process and kind of just recovering is the milieu, the community, the groups that we do, like the process groups, right? Those are really good for people learning just how to communicate well and in a healthy, respectful manner. And so, so those are some of the big ones we do. As far as psychoeducation as well, we have, like every week, we call it family systems group. It's not the family system. It's not IFS or nothing like that. We just kind of call it that. I'm looking for a better name so people aren't steered incorrectly with that. But it's around relationships, communication, boundary setting, codependency, rebuilding trust. Where addiction is present in a family, and I think I'm stealing this from Hazelton, Betty Ford, but there's this environment of, don't talk, don't trust, don't feel. So a lot of these folks are coming out of really dysfunctional family systems where it's not just the identified patient, right? This is a family system that can be contributing to this disease. So yeah.
I'll make sure you got to know where you got that so that I can get credit when I use that don't talk, don't trust, don't feel. Because I like that. I mean, that is, if anything we're pitching on this show, that is the general mindset. I mean, you could say of men, but you really could say of society at large. I mean, I don't think it'd be fair to only say that men are given that attitude growing up, because it's generally a product of the environment and goes all the ways around. Brian, I'm interested because we haven't talked about CBT in a little while on this show. So just the thoughts are what interest me, Brian. When you are working with people in CBT, what are some of the most common cognitive distortions you see? Like consistent monologues? What are some themes you notice amongst people who are struggling at this level with substances?
What I've seen, like my experience has been mostly with these really self-defeating, self-sabotaging thoughts. These thoughts of, it's been ingrained in my head so long that I'm not worthy, that I'm not deserving. This is how I think about myself. This is how I think about the world. Being caught in that mindset without being able to have the freedom to process it in a safe place. Yeah, I mean, folks are going to create their own kind of mini worldview of what this looks like for them to even operate in a healthy way. And so it's really reframing those thoughts and helping them see those apart from who they are as a person. Kind of like, I'm not a bad person. I might have a quote unquote bad or unhealthy thought, but it's helping them see these kind of as just two separate entities that
right?
Yeah,
and it's wild,
right.
Brian. I ask probably everyone I've worked with, hell, I ask my friends and family, like, do we believe we are in control of our thoughts? And most people say yes, which is wild when you think about the amount of thoughts we all have every day that are quite frankly disturbing. And so, you're on that path of helping people understand, like, this is what you've been wired up to think. It does not make it true. We have to understand where these ideas come from. And Brian, you hit the nail on the head with that don't talk, don't trust. Like, you're in the military, or you were, this story. Trauma changes the way we view ourselves, others, and the world around us. And so when you have a feeling of instability, unsafe, people can't be trusted, you can't be trusted, all that stuff, it's easy for anyone listening to the show to understand how that can get to a place of lack of worth, self-doubt, the things that would drive substance use. It's relatable.
Yeah. And, that's why I really love that simple yet I think profound DBT concept of the dialectic of replacing but with and, right? Like I can say I've made a bad mistake. I've hurt people by my drinking, my drugging, whatever, and I am still worthy of recovery, right? Not like you're discounting everything because of that, right? No, I mean, yeah, these are some things you did. Let's set them aside and let's look at them. Let's reframe them. Let's kind of figure these things out. And you're still worthy of this positive trajectory and health and life and joy and all this stuff.
Totally. So, it's there's so many factors that contribute to people struggling with that. We talked a lot about, obviously, the replacing your butts with ands, and just the idea that when we grow up, we protect ourselves to, see the world as black and white. And you have to really grow and mature beyond that to really be able to trust people and see that the world does exist in a lot of gray. And, when you're dealing with people who are struggling with substances, unfortunately, a lot of them have had situations come their way, either when they're younger or older, that shift them back into that black and white thinking and make it hard. So you saw my reaction when you brought up the replace your butts with ands. I must say that, I don't know, Richie, you're listening. I know you've heard me say it a million times, but I probably say it 10 to 20 times a week in my practice, in my life, and my girlfriend's annoyed by it, all that stuff.
Yeah. It annoys my wife a little bit too, especially when I get super judgy when she doesn't do it, right? No.
Yeah, but also then there's the people who are like, I meant but. And I'm like, okay, yeah, I guess sometimes it makes sense, and so that's why I love it when I have patients who will be like, no, I meant but. And I'm like, yeah, okay, sorry, like, love you. Well, you brought up your wife. Speaking of family, like, I know it was huge when we were in the eating disorder world because I work with teenagers. So the family had to be so deeply involved. But you're working with adults, Brian. So how is the family involved in treatment?
Good question. I'm glad you asked, because when I started, I mentioned in 2019, I was working with the family program. At the time, we did have an in-person week-long family program, which was pretty cool.
Oh, that's
we
cool.
do stuff. Yeah, it really was. It was very impactful. We have like a virtual program now. So kind of how we do things in residential is, of course, if a patient wants to have a family member, friend involved in their treatment, yes, they have to fill out the release of information so we can get permission to communicate with them. So if they do that, then that's great. We'll reach out to the family member. We'll send them an email. We'll give them a call. We'll invite them into the treatment experience. We have a couple virtual family support groups that CeDAR offers as well, so they can plug in with other peers that are going through a real similar journey that they are. Because again, we do believe this is a parallel process when it comes to addiction and recovery. And then also, if all parties are in agreement, like, hey, would it be helpful to have a family session? Yeah, we can do that. We absolutely do. Or we'll bring family members, friends in. We'll do a family session or 2 or 3 or however many. I can't speak for the other counselors on my team. I don't know what they call it. I don't really consider it family therapy per se.
Yeah.
We're not getting into like IFS. We're not getting into like deeper issues that have been,
which would be, in the outpatient world, right? Like, because we could, in most cases, some cases, right, assume that there is, especially for the younger people whose parents are involved or, loved ones, family, husband, wife, any of that kind of stuff. Like, there's stuff to be worked on. Really, there's stuff to be worked on for any of us. So, got to assume in a situation like this, there's growth to be made. And I think what I hear you saying is like, we're going to start that kind of stuff, maybe draw attention to it and make plans for outpatient world, kind of those next steps and what needs to be done.
Yeah, no, that's exactly that's how I handle it. When I have family sessions, we come in and we just learn basic communication, right? It's like, okay, you get 5 minutes to kind of say what you need to say, and then I'm going to have the other person reflect back what they heard. Did you actually hear what that person said? And oftentimes, no, they miss a lot because there has been unhealthy communication, right? And so it's setting a foundation for learning healthy communication. And then to your point, also, what is this going to look like after discharge? Because, patients are in there for 30, 45 days. It's kind of a bubble, right? They leave here and the world is still turning. So what does it look like for the family member to support them in a healthy way, not enable them, but support them while each person finding their own journey and then kind of merging together. So it's certainly, I wouldn't say we can do like long-term work here, but it's setting the stage for it. Yeah.
I've asked a couple people this in our show while we've been on the addiction. What is your opinion and the difference between enabling a loved one and supporting a loved one?
If what this person is asking of you is supporting their recovery, if it's positive, if the choice is a healthy one that is going to help them heal, help them recover, then that is supporting, right? So like an example of that is like, okay, maybe this person wants to go to sober living, right? And they just don't have the intake fee, right? They don't have however much it costs. So they're going to ask mom for it, and this is just hypothetical, of course, but that would be my example of like, okay, maybe mom in that situation would say, well, this is supporting my loved one because they're making a positive choice for their recovery. Enabling would be like, okay, maybe that person discharges without a plan, no aftercare plan, and is like just saying, well, I'm just going to kind of go live back with mom. And, and I just expect, everything to kind of just be given to me, room, board, everything. Now that is a complicated situation, right? Yeah. That's where we talk about how do we set boundaries? What is a boundary? How do we communicate it? Is this something that this mother or, parent is setting for their own health, right? For their own well-being. And so that's kind of how I look at those two. Yeah.
Shout out moms, Brian, and make sure you remind your wife of this later. Even in your hypothetical example of a question I had not prepped Brian for, moms are holding the bag. So shout out moms, just all the love in the world. I got one, you got one, you're married to one, all that stuff. So, it's interesting you brought up this prepping for discharge. I think that is something that the vast majority of our audience has not been to rehab, and it's like a really complicated thought. So I'm curious not only how that discharge prep looks like what are you making sure people have in their bag, these kinds of plans, but thinking about that discharge prep.
I'll kind of explain it as a kind of a continuation of care, like in a perfect world, what would this look like, right?
Of course.
And so after someone would discharge from residential treatment, maybe the next step for them would be what's called like PHP, partial hospitalization program, which, different programs have different timeframes for that. But generally speaking, it's about maybe a 4 to 6 week program where it's kind of like your job. It's day treatment, right? You go from 9 to 5, you're getting treatment. PHP, you're looking at about 20 hours of treatment, 20 hours of treatment per week. So that would be the, I guess a logical step
Yeah.
down. And then the next step from that, as far as treatment goes, would be IOP, intensive outpatient treatment. It's about 9 to 10 hours of treatment per week. You're talking like, 3 days a week, 3-hour groups, things like that. And then you would have a step down to like a continuing care program where maybe you're meeting once a week. And I'm saying this from like a treatment perspective. Like, what does this look like clinically, right? Because the other person or the other part of the story is, are they attending fellowship meetings? Are they attending support groups? Are they connecting with some kind of recovery community? Are they, taking care of their fitness and their diet and all these other things that contribute to a healthy lifestyle, right? Are they doing these things? So as far as continuum of care, that's what that kind of looks like. Discharge planning, of course, is tailored to the individual's, I'd say, needs and also limitations. And so oftentimes people want to go back to work. They got families, they got to pay the bills, they got to do these things. That PHP, that's just not reasonable, right?
Yeah.
And so IOP is like, okay, well, I can do this. I can go to some meetings. I can still go to work and provide for my family or provide for myself. So it's really tailored to that person's life after treatment. Or it gets a little sticky because you probably heard this phrase of, got to put your recovery first. Recovery comes first, and I do believe that. I do believe that to a degree, but I can't, I'm not going to tell somebody what that exactly looks like because, and I said this the other day in group, we talked about this. I'm like, you guys hear this a lot, right? Put your recovery first. What about life? Life is going to throw you some things sometimes.
Kids and your,
you can't do it. Right.
It's a somewhat privileged position for those who have the resources and the housing stability and those kinds of things to be able to do that.
I say that kind of carefully because then my colleagues might slap me. I don't know. But I mean, the thing is, like, maybe it's more anecdotal, maybe it's more personal because there were moments in my life, and there still are, that I have to miss my meeting because I got this, or maybe the car broke down, so I couldn't even get there, so I now have transportation issues, or whatever the case is. Like you said, kids, right? And so I have to find other ways to connect to my recovery when my plan doesn't go as scheduled. So anyway, kind of taking it back to the discharge planning. So yeah, we'll sit down with folks. Like we have case managers, and also it falls on the counselor oftentimes to,
I'm sure,
because we're establishing that rapport, we're kind of working that motivational interviewing, we're kind of seeing that change, so we have some leverage there. So yeah, it's really encouraging people to do things differently. Yeah, you haven't tried sober living? Okay, try sober living. Let's see how it is for a few months. Do a little IOP. Get a sponsor, things like that. So we're really trying to, again, encourage, tailor, and of course, use therapeutic interventions to hopefully get them to commit, which I think takes us into that next question about stage of change, right? Yeah.
Yeah. Like, how many people do you think are, truly ready for the maintenance stage when they walk out the door? Or do you even really consider, I'm not sure when action to maintenance in recovery changes. You've experienced it. How do you see it?
I know the question say what percentage, and I was thinking about that. If I had to put a percentage on it with no research behind it at all, right?
Yeah.
The percentage of folks leaving residential treatment in the action stage of change, maybe 10%.
Man.
Because when we're talking about like pre-contemplation, contemplation, that's where most folks that I work with are for the duration of their stay. And when I do assessments on them, when I write up clinical notes on them, this is something we assess for every time we meet. Like, where are they? And every now and again, I'll put like the determination, the planning stage in the notes. Like, yes, this person is there. I don't know, and I'm not like I've been doing this for decades, but I don't know if I've actually put anybody, maybe once or twice I put someone in the action stage because, it's just that ambivalence, right? It's that ambivalence of these major changes in someone's life, someone coming out of addiction for many, many years, and then in a short amount of time, trying to make these life-changing decisions that it's the unknown. They have no idea what this is going to look like, right? So the commitment to actually like take these steps is terrifying. So I'd say most folks are coming out of it in the contemplation kind of planning stage.
Yeah.
Every now and again, some action in there. Yeah.
Yeah, I think it's a fair way to look at it. And it proves the point, one, that the way we're going about this here may be rosy-eyed, as sometimes we are wont to do, but also that it is not a straight line. We've talked about grief a lot on the show, Brian. Same way, is that like you go forward, you go backwards, relapse is a part of recovery. And so just kind of naming that for you, I'm sure it's great to see people progress, and I'm sure that you've got your worries. I know I did in that eating disorder world. Like, you have worries when people walk out the door, and as the old insurance adage goes, discharge planning should start the day of admission. So we're always on the clock, and it's not like we can keep everybody forever. As we get close to wrapping up here, Brian, I want to think about all the patients you've had, yourself, I mean, peers of yours in recovery. What are the factors, the strengths, the qualities of a person who does well in IRT versus those who don't? You can take them one at a time.
I would say key factors for those that thrive. I mean, I'll keep it as simple as I can. Because two words came to mind: willingness and connection. Because listen, I mean, we can do all the interventions we want. All the evidence-based, this, that, the other. We could put a solid. I mean, on paper, we can put like the best treatment plan, aftercare plan together and say, yeah, this person is gonna succeed. And if the willingness for them to do something differently is not there, then, well, yeah, it's not going to happen. So I'd have to add humility into that too. So willingness, humility to say, okay, I really don't like the way I was living. I don't like anything about that. That was destructive. I've caused a lot of wreckage in my past. And I don't want that anymore. And that just pure desire to say, I am willing to commit to go to any lengths for my sobriety, for my recovery, even if it means doing things I've never done that are scary and unknown and completely different from the way I view the world. So that would be the one. And then connection is, human connection, right? I mean, we kind of know this, right? This whole, like, I can't do this. I certainly can't do it alone. I can't. I tried and I failed, and I tried and I failed, right? And so, you'll hear that in recovery circles, connection, you'll hear it. So what does that actually mean practically? Well, I think for me, that means, again, the willingness to actually pick up the phone, go to a meeting, connect with other people in the program, even when I don't want to.
Tell the truth. Tell the truth.
That feeling. It's saying, okay, I'm not going to let my feelings are valid. This is how I am. This is how I'm showing up today. I'm miserable today. Okay. And I'm not going to let that dictate the rest of my day, because I know I have a choice. It's still that choice in the matter of saying, I can pick up the phone. I can get in my car and go to that meeting. I can go to that group. Right. And so it's, I won't get too much off on a tangent, but that's what I'd have to say is, humility, willingness, and connection, all with the pure desire to just do it regardless of how you feel.
It's interesting. I think connection is almost like the opposite of that don't talk, don't trust, don't feel, right? Because when you're connected, when you have good, deep, authentic, pure, true connections, there is no choice but to talk, trust, and feel. And so it's really, human connection and not being alone. Men in general are so alone with their thoughts, their feelings, and their state of being that we could really think of good, authentic, vulnerable connection is the treatment. I wouldn't like to say the cure, but the treatment, for a lot of these things. So, and then you touched on humility, which I'll just jump in. Like, I know you're a big advocate of the fellowship programs, the AAs, and those straight up require humility, right? I don't know what step it is, and we're going to be fortunate enough to have Brian come on and teach us about AA in a couple of weeks. But I know one of the steps is that we have to admit that we're powerless. Humility to be able to say, like, can't toe the line here anymore. It is not doing me well.
Yeah, and some of the things I've probably mentioned, will point to, the principles of the fellowship, right? Willingness is actually one of them. Like there's three main spiritual principles: honesty, open-mindedness, and willingness. Those are three key components to recovery. And yeah, I would agree with you on the step one. We admitted we were powerless, and I'm looking. I know I can go all day on that stuff.
Brian, you mentioned you're a big reader and you've got good experience in this field. You're certainly in our demographic of a kinder, gentler bro. You got a content rec for the people? Book, show, movie, something that you think does a good job of portraying the addiction world or the IRT world?
I'll just mention one book that's been pretty impactful in my life. And there is a spiritual component to it. So, I mean, take it or leave it, for whoever wants to pick it up. But it's called Addiction and Grace. And the author is Gerald May. And it's an easy read. It's not super thick. And it really breaks down like the biology of addiction, the psychology of addiction, and also brings in like a kind of a spiritual aspect to it. And so that was just, I don't know, it opened my eyes to, well, as the title says, addiction and grace, right? I mean, it's been my experience that I think we're getting better. I hope we are culturally, so societally. that we are getting better to shatter that stigma of addiction, right? And I think one of the quotes that sticks in my mind from that book is, "To be alive is to be addicted, and to be alive and addicted is to stand in need of grace." And so it's just, I don't know. That's one I'll just throw out there.
One, only $8.99 on Amazon, so certainly affordable for most of our audience. And it does. I'm just reading through. Does a nice job of touching on the biology, the psychology, and the social, which is often involves the spiritual connection in people's lives. And it's interesting. And maybe we'll do this in the AA episode, like what's spiritual versus religious. How are those things different for people? Those kinds of things, because that kind of stuff is important for everybody, and it can look different for everybody, and that's what the most important part is. So
yeah, and Stephen, I tell you, I would love to talk about those two specific things, like the differences between spirituality and religion.
Great. I'll add it to the list of questions for next time. Go Birds. Great to have you, man. This was so much fun, and the opportunity to give our audience a straight up tour of the experience in the facility at CeDAR has been truly a blessing. So thanks so much for your part in that.
Yeah, you're welcome, Stephen. Thank you. Honor to be here.
To make sure Richie had no say in the matter, that's right. You see your host over there with a solid finger spin. We'll skip the few that weren't as good. I did get to choose when we started this video. So here we are in the outdoor area. You can see beautiful campus. You can see the major hospital over there in the background of UC Health, and beautiful day here in Colorado. So this outdoor recreation area, it's pretty abundant. You see the basketball court where your boys, Steven and Mario, are hooping a little bit. In the background there, you can see a community garden that during the summer is a big part, again, of establishing healthy habits, feeling purposeful, feeling motivated, bringing life into the world are all great things to help people who are struggling with addictions of any kind. So getting out in the rec area, there's different games, cornhole, kickball, basketball, and all that stuff that's, again, meant to help us connect with our inner, positivity, our inner healthiness, and really just being outside and making sure we're not in our head, we're out in the world and doing well. So we'll kick it over here. Speaking of getting out of our head, over to the Spiritual Center, which you can see on the 360 there, to think about how spirituality plays a role here in treatment. And we've made our way into the Spiritual Center here. And so anytime you're looking to help yourself in a state of issue and trouble like addiction causes, you're going to be looking to center yourself, to ground yourself. And spirituality is a huge, huge part of that here for the patients at CeDAR. They have an on-site chaplain. In fact, I learned that they actually have a chaplain training program here for people who want to be hospital chaplains and working with people in the medical setting, which is a super cool program. But yeah, non-denominational Spiritual Center here. They'll have holiday celebrations if people unfortunately have to be in treatment over some of the major holidays, and just really see this as a place also for patients to come, and beautiful stained glass, and as you can see, a pretty beautiful building overall. So this is where we'll kick our tour over to our friend Shirley. She's a business specialist, and talk about the money part, which is an unfortunate, true, real part of treatment. Be right back. We're fortunate today, guys. We've grabbed Shirley, who is a business specialist here at the treatment center. And we've talked a lot on the show about access to resources, the money part, and that insurance money is often a barrier to care for people to seek mental health treatment. So in your experience, Shirley, how does, the business aspect and the money impact treatment for people?
Well, first, it matters if somebody has insurance.
Yeah.
All right. That's just one layer. And then, is the treatment center you want to go to in network? Is it out of network? Do you have out of network benefits at all? Self-pay is something that, probably ranges between $900 and $1,500 a day.
Yeah, sure.
For residential treatment. That doesn't include the assessment to get into the treatment center. It doesn't include the first day assessment.
Right, because there's probably like doctor's fees and like the fees of the individual practitioner separate from the facility fee?
It depends on how the facility is set up.
Yeah.
Most of them are it's like a hospital bill. It's like a hospital inpatient bill. There's some social detoxes that don't do any medically assisted treatment, with medication for withdrawal management and so forth. And so a lot of times those will have separate fees, and it's a lot cheaper.
Yeah. How often are patients doing self-pay?
Percentage wise, I don't know, maybe 10% of the time or less.
Do you think people who have those resources are going to, fancier places like you might picture a Malibu Rehab?
There are definitely levels of fanciness, if you will. Yeah, so there are places that are like for celebrities, you know,
Right.
Betty Ford or your whatever you
Yeah.
might consider. For the rich and famous, there are some that are in mountain areas, right? That are exclusive and they're all private rooms and very, very secluded and fancy and so forth. But then there are others that have a lot of demographic mix,
Sure.
right? So
That's what I would
there's
think we are here because we're at a public hospital in a major city. So I'm sure we get a wide variety of SES levels here.
for sure we have everyone from transient folks that are, you know, now homeless to attorneys and politicians and rock stars. Like it's just,
Yeah.
it runs the gamut. It does not discriminate.
Do you happen to know what are those fancy treatment centers? Like how much are they paying a day? Like what's that?
Don't. I think one that I looked at for adolescents last year, normally at about 1,000 a day, you're at
I
30,000
was
a
gonna
month.
round up to 10,000 a day. Yeah, for sure. I was like, yeah. So one thing I'm wondering is, from that insurance perspective, like what's the process with the insurance and are you any doctors listening? Please cover your ears. Do you do prior authorizations and all that stuff you have to deal with? I'm sure.
For sure. So when you walk in the door, the first thing our admissions team wants to do is determine a level of care.
Yeah.
So they'll do a level of care assessment and see where you belong on the care continuum.
Yeah.
Once they've done that, we're going to ask authorization from whatever insurance company you have. We do want a pre-authorization. Now, they always give you that disclaimer. Pre-authorization is never a guarantee of claims payment.
Yeah.
Right. So you probably heard that on your automatic.
I know anybody in here for surgery, for an MRI, you're always going to see that in the fine print. Like it'll probably be covered.
Yeah. We may or may not pay it.
Yeah.
Yeah, we do ask for pre-authorization because that's our best bet of getting it covered for a patient. And that's always for the benefit of the patient. At the end of the day, the patient's responsible for the bill and they sign paperwork that says that they are.
Yeah.
But we don't want to put people through that.
Yeah, of course, of course. I mean, I worked at a residential treatment center for eating disorders here in town. And, I was, as a physician, pretty consistently, doing prior auths and doing peer-to-peers with the insurance. I'm sure it's pretty similar for the clinicians here.
Very much so.
Yeah. What length of coverage stay? When do you start running into those things? It's based on like the patient's clinical status. Like when do you start getting pushback from the insurance?
Yeah, it is based on ASAM criteria. So it's medical necessity based and it varies by insurance company.
Yeah.
So there are some major companies that will only cover typically 10 to 14 days. And they say it's all medical necessity based, but then we'll see some similar client and they won't get as much time. And so it can be pretty subjective on the part of the insurance reviewer.
Sure.
So as much as we might try to give them good information, they'll kind of at their mercy.
I think ASAM is a new word for our audience. And so that's American Society of Addiction Medicine. What do you think at the end of the day, say a 6-week stay here with reasonable insurance coverage, how much do you think this is costing somebody?
So
like copay, deductible, depends.
It's cool to say because everybody's copay and deductible is different. Their out-of-pocket max is different. And that's really tough to say. But I mean, if I could guess a very wide average after insurance for a 6-week stay.
Is that about average?
Like about 30 days because it's just what we see more often.
Yeah.
Gosh, I would guess it's still probably costing around 5,000.
Yeah.
Somewhere between 5 and 10.
I think it may, it's not a lovely number, and no, we're not going to say that's not a lot of money. And I think just sitting here realistically sounds right. Sounds about what I would have expected, I guess. Right is neither here nor there, but what I would have expected.
I'm sorry to interrupt. I was thinking, considering what addiction causes and the havoc that it wreaks on your body, you could easily spend that in an inpatient unit on a medical floor.
For sure.
Spend it one way or the other. Let's spend it getting clean.
Oh, absolutely. For perspective, $5,000 to $10,000 is one night on an inpatient unit. Yeah. More. With cover, less with coverage, but that's how much they're billing for one night. Yeah, it's really interesting, and it's unfortunate, as we talked about on the show, that this isn't access to care. My last thought, because we just turned over to the calendar year. Do you get a big rush of people who've already paid their deductible who try to get into treatment at the end of the year?
Interestingly, yes, some people do try to rush in, but with this particular disease, It's more about I'm not ready to get clean until after the holidays.
Yeah.
I'll see the rush in January. Yeah, but also considering access to care, Medicaid didn't ever used to cover addiction recovery, and it does now.
Yeah.
So that's something that I think people need to know, because if you have been in this game long enough that you don't realize it will cover you now, it does.
I was just getting a tour with Dr. Perez, and I was like, oh, so there's no way that Medicaid is, we see Medicaid patients. He goes, no, actually one of the better payers. Like he gives you good lengths of time. And even just, I've been out of this game for 3 or 4 years, and just kind of like this kind of a public hospital setting. And yeah, I mean, that's changed. I know in eating disorder treatment, they're pretty specific about where they'll send places, at least here in Colorado. So that was my experience in this world before, not substance. But yeah, no, that's a really great thing. And as far as access to care goes, to have treatment like this covered is apparently a new thing, which rules.
Yep. And you'll find probably at your next stop that no one will cover sober living.
Yeah.
And that is really upsetting.
Yeah.
I wish they would.
Yeah.
Because it's just part of the care continuum. You can't put somebody back in that same environment and expect them to still do as well as they would in a structured environment. So it's really critical, and I wish that would change.
Yeah. Maybe in our lifetime, Shirley, but unfortunately something we know is that prevention, doesn't really get paid for very often, and wellness programs. And I'm a big advocate for like social emotional learning curriculum in schools, and like you would need to think ahead, right, for those kinds of decisions to be made. So either way, thank you so much for your time. We just kind of popped in on Shirley and said, will somebody talk money with us? And thank you so much for your time. Really appreciate it.
Nice to meet you.
All right. We'll check with you guys after the break.
So we'll wrap a little different than we usually do, as the grounds of CeDAR remind us that kindness matters. I want to shout out the staff at CeDAR, the administration that allowed us to come on site and tour. Of course, Dr. Perez, Brian, and Shirley for their time and insight as we all look to build empathy and understanding into what the rehab and addiction treatment world is like. Thank you, KGBs, for tolerating some technical difficulties in our first shot at working on site and shooting in this way. So if you have ideas of things that would be cool to see on site, or ideas, please shoot them our way. We're trying to do new things, cool things, and things that resonate with people. What did we learn this week? What are our takeaways? We don't really understand something until we see it with our own eyes. We're always going to try to encourage that from you guys. One, that addiction, rehab, it's a motherfucker. You need family. You need spirituality. You need a healthy body. You need a sound mind. And we're seeing that an inpatient treatment center like this tries to focus on every single aspect of the human. And 3, thank you, CeDAR Grounds, for helping us end as we do. Kindness matters. While you're out in the world this week, try and be kinder and gentler. See you next time.